This talk is about primitive reflexes and postural reaction. This talk will be conducted using a question and answer format. First question: from 3 to 9 months of age, infants' movements can be classified as A. Primitive reflexes, B. Postural reactions, C. Volitional movements, D. All of the above. This chart illustrates the nature and course of motor activity during the first 12 months of life. In the chart, the x-axis indicates time in month 0, the time of birth, in this illustration corresponding to 40 weeks of gestation. The parenthesis confines prenatal life. -3 indicates 28 weeks gestation. The thin line separates the absence from the presence of motor activity. Below the line, the absence corresponding to 0, no motor activity. Above the line, the presence. The 1+ indicates minimal motor activity. The 3+ indicates maximal motor activity. Motor activity during the first 12 months of life can be organized into volitional motor activity, corresponding to an activity under volitional control, postural reactions, referring to an activity not under volitional control and not present at birth. Postural reactions are considered reflexes, and their purpose is to protect the infant and initiate locomotion. Postural reactions ultimately become integrated to volitional motor action. The third type of activity present during the first year of life is primitive reflexes. Primitive reflexes are brainstem or spinal cord mediated activity not under volitional control and present at birth. Primitive reflexes have at least 3 purposes: to exercise muscles during intrauterine life, to help the baby come out of the uterus, and to keep the baby alive during the first weeks of life. They are present prenatally and either become integrated into postural reactions or into volitional motor actions, or they can also disappear, usually before 9 months of age. Between 9 and 3 months of age, we find the 3 types of motor activity. So the answer to this question is D. Next question: which of the following primitive reflexes or postural reactions is initiated by activation of muscle receptors? A. Galant reflex, B. Labyrinthial writing reflex, C. Kinesthetic head writing reflex, D. Landau reflex. Primitive reflexes and postural reactions are both triggered by endogenous or exogenous stimuli and not under voluntary control. In this frame, I have summarized structures that, when activated, can elicit primitive reflexes and postural reactions. They include cutaneous receptors, balance receptors housed in the labyrinth, acoustic receptors, light receptors, and proprioceptors present in muscles and ligaments. Signal from the skin conveyed by mechanoreceptors trigger the Galant reflex. This reflex can be evoked from ventral suspension or prone position as presented in this frame. The stimulus consists of touching and exerting some pressure on the lumbar region lateral to the spine. The evoked action consists of flexions of the trunk towards the side of the stimulus. This reflex is present at birth in premature and full-term babies and disappears by about 3 to 4 months of age. The figure in this frame shows that the Galant reflex is present in a few 25-weekers and is found in a progressively larger number of premature babies as they mature. It was present in all 37-weekers. By 39 weeks, a large proportion of neonates, in addition to trunk incurvation, show hip elevation with this maneuver. So we have gone through an example of a primitive reflex triggered by cutaneous stimulation. We will now go through a postural reaction triggered by a vestibular stimulation. Such is the labyrinth head writing reflex. This reflex is elicited by changing the trunk position in relation to gravity. The evoked action consists of movements of the head to achieve a position in which the vertex is uppermost and the mouth is horizontal. This reflex is very prominent in cats, but not in just born kittens. I will illustrate it in the next few frames. In the presence of normal vestibular function, a cat thrown leg up in the air will land on its feet. If, in the presence of an intact vestibular system, we cover the eyes of the cat and throw it in the same fashion, the landing will be similar. But if the vestibular apparatus is destroyed and the cat with the eyes covered is thrown leg up in the air, the cat will land on his back or side. This nasty experiment proves that the functioning of the vestibular system is necessary for spatial orientation of the blinded cat. In humans, the labyrinthine head-righting reflex is triggered by several maneuvers, such as changing the position of a blinded infant by vertical tilting, as indicated by the yellow arrows. Such maneuvering will trigger head alignment with gravitational forces, as indicated by the green arrows. Labyrinthine head-righting reflex can also be triggered by holding the patient parallel to the ground. This position triggers the Landau reflex. This reflex is manifested by extension of the neck to achieve a position in which the vertex is uppermost and the mouth horizontal to the ground, similarly to the labyrinth head-righting reflex. Labyrinthine head-righting reflexes appear by about 4 to 6 months of age and become integrated with volitional actions later in life at about 1 year of age. After talking about labyrinth head-righting reflexes, we will mention an auditory mediated reflex, the auditory orienting reflex. This reflex can be triggered by ringing a bell about a baby. The action consists of turning the head towards the side of the sound, but not aiming at the sound source. This reflex is first noted at 3 to 4 months of age and is incorporated into volitional actions of point source localization a few months later. By 7 to 9 months, it requires separate horizontal and vertical head movements, and shortly after 9 months, the infant will look at the source with single directional movement. We will now go through a postural reaction triggered by visual stimulation. In this group, I will mention the blink reflex. This reflex is present during the neonatal period, later becoming bionatural action. This reflex is achieved by shining a light in the patient's eye, as illustrated here. In a 26-week gestational age neonate, the exposure to light produces repetitive blinking, whereas by 32 weeks, exposure to a bright light will produce sustained eye closure. I will now talk about a primitive reflex brought about by activation of proprioceptors. In this category, we have the kinetic head-righting reflex. This reflex is brought about by stimulating axial musculature proprioceptors. This reflex can be triggered by 2 maneuvers. One, by rolling the baby's trunk. This maneuver activates axial musculature proprioceptors and elicits head realignment with the trunk. Another way to trigger the kinesthetic head-righting reflex is by head rolling, which especially activates neck musculature receptor and elicits turning of the trunk to align with the head, as you can see in this frame. The kinetic head-righting reflex initiated by cephalic or truncal movements is present at birth in full-term neonates, and it incorporates with labyrinthine and visual righting reflexes after 3 to 4 months. So the answer to this question is C. Which of the following reflexes persists the longest? A. Plantar grasp reflex. B. Magnetic reflex. C. Stepping reflex. D. Placing reflex. In the course of answering this question, we will talk about 6 reflexes. Reflex number 1, the plantar grasp. The plantar grasp reflex is activated by applying pressure at the base of the toes. This maneuver elicits plantar flexion of the toes. Toe flexion disappears when pressure is lifted. The plantar grasp reflex is present in premature neonate as early as 25 weeks. It is fully developed by 32 weeks. It is remarkably constant at birth and during early infancy. The plantar grasp reflex usually disappears by 12 months of age. The second reflex we will address is the palmar grasp reflex. The palmar grasp reflex is triggered by applying pressure over the palm and subsequent traction of the arm as shown. The first part of the maneuver elicits finger flexion, and the second component reinforces the grip and elicits flexion at the elbow and shoulder. The time course of this reflex differs in different publications. Nelson textbooks of pediatrics states that it is first noted at 28 weeks, fully developed by 32 weeks, and disappears between 2 to 3 months of age. Other authors describe this reflex as being present as early as 25 to 26 weeks post-conceptual age, at the time limited to finger flexions, and by 29 to 30 weeks elbow flexion is first noted. yet other authors reported it being present even earlier. This intrauterine ultrasound was done at 16 weeks. In it, you can see the cord and the hand grasping it. The third reflex is the magnetic reflex. The magnetic reflex is present in term neonates at birth. It is triggered by pressuring the sole and slowly pulling back the thumb. As you can see in this frame, this maneuver elicits the feet to follow the thumbs. It is gone by 3 months of age. Fourth reflex is the Bauer reflex. The Bauer reflex is performed with the baby laying face down. It is activated by applying pressure to the soles of a newborn's feet while keeping the hands in place. It triggers crawling-like movements leading to forward displacement. This reflex has been reported in 28-week premature neonates and it is fully developed at term. It is gone by 3 months. The fifth reflex is the stepping reflex. The stepping reflex is activated by supporting the baby in a standing position and leaning the baby forward. It elicits alternating flexion and extension of the lower extremities. This reflex may not be present even in healthy full-term neonate. When present, it is gone by 3 months. The sixth reflex is the placing reflex. The placing reflex is triggered by holding the infant in vertical suspension. Then the skin of the dorsum of the foot is brought into contact with the edge of the bed or a table, as indicated here. This elicits initial flexion of the hip and knee, followed by extension. This reflex is more consistently found in full terms than the stepping reflex. It is gone by 3 months. So the answer to this question is A. Next question. Which of the following is not considered a primitive reflex? A. Symmetrical tonic neck reflex. B. Tonic labyrinthal reflex. C. Routing. D. Glabellar. In this question, we have listed 4 reflexes, and during the process of answering it, we will talk about them. Number 1, the symmetric tonic neck reflex. The integrity of this reflex is assessed by using 2 maneuvers, the forward and the backward maneuvers. The forward maneuver is performed with the patient sitting with or without support. The maneuver consists of flexing the neck. Such maneuver elicits arm bending and leg straightening. The backwards maneuver is performed in the same sitting position by extending the neck. The extension of the neck is followed by a straightening of the arms and bending of the legs, as you can see in this frame. Both of these maneuvers are important because they indicate the beginning of independent upper and lower body movement. They are first noted at 6 to 9 months of age and become integrated with volitional actions between 9 and 12 months of age. Number 2, the tonic labyrinthine reflex. This reflex is similar to the just discussed symmetrical tonic neck reflex since it can be triggered by 2 maneuvers, the forward and the backwards maneuver. The forward maneuver is performed while the infant is resting on the examiner's hand. It is then that the head is flexed. This action elicits the pulling up and coming together of limbs close to the body. This reflex is present in uterus and disappears by 4 months as it gets integrated with postural reaction. The second maneuver of this reflex is referred to as the TLR back. This reflex is elicited by extending the head to below the level of the spine while the patient is resting on the examiner's hand. The elicited actions consist of arm and leg extension away from the body. This reflex is present at birth and is integrated from 6 months to 3 years of age. As reflected by its names, experiments in animals have implicated the vestibular system as the triggering structure. Number 3, the routing reflex is activated by touching the corners of the mouth, as you can see here. It elicits mouth, tongue, and sometimes head deviation towards the stimulus. This reflex is also called the cardinal point reflex because it can be elicited by stimulating on the 4 cardinal geographical points around the mouth. Some authors have found this reflex difficult to elicit except when the patient is near his feeding time. It is first present at 32 weeks, fully developed by 36 weeks, and become less prominent after 1 month. It disappears by about 2 to 3 months of age. Number 4, the glabellar reflex is elicited by tapping the forehead between the eyebrows and nose. It is present in full-term neonates and is gone by 3 months. So the answer to this question is A. Next question. Which of the following is considered a primitive reflex? A. Landau reflex. B. Symmetrical tonic neck reflex. C. Asymmetrical tonic neck reflex. the parachute reflex. Again, in this question, we have listed 4 reflexes. The first 2 we have already discussed, so they will be only briefly mentioned. Number 1, the Landau reflex, which is considered a labyrinthine head righting reflex. As you recall, this reflex is triggered by holding the infant parallel to the ground. This position elicits the extension of the neck to achieve a posture in which the vertex is uppermost and the mouth horizontal to the ground. Some authors make a point of describing that flexing the neck terminates this position, causing the arms and legs to flex. As previously mentioned, this reflex is first noted at 4 to 5 months and disappears by about 1 year of age. Number 2, the symmetrical tonic. This reflex is first noted at 6 to 9 months of age and becomes integrated with volitional actions by about 3 months after it appears. The third reflex mentioned in this question is the asymmetrical tonic neck reflex. This reflex is elicited by turning the head to the side, which produces cervicovertebral proprioceptor stimulation. The triggered action consists of extension of the limbs on the side of the face and flexion of the limbs in the occipital side. This posture has been referred to as a fencing position, but obviously it is not, since as you can see in this frame, the fencing position consists of flexion of the leg on the facial side, unlike what we find in this reflex. The posture found in a symmetrical tonic neck reflex is more like the one achieved by a baseball player when trying to reach a ball, as you see in this frame. The table in this frame illustrates the frequency of asymmetrical tonic neck reflexes in premature and full-term neonate. As you can see, this reflex is present as early as 25 to 26 post-conceptional age and perhaps even before. Some authors date the initiation of this reflex to 18 weeks, but I was not able to find the source of this claim. At 25 to 26 weeks, visible postural changes are present in 40% of cases, with just about half of them having a typical posture. At 37 to 38 weeks, all patients had visible changes in posture and about half had the typical posture. The asymmetrical tonic neck reflex is no longer found after 6 to 7 months of age. Spontaneous asymmetrical tonic neck reflex can also normally occur during the first 6 months of life, as you can see in these photographs. The fourth reflex listed in this question is the parachute reflex. The parachute reflex has 3 types: forward, lateral, and back. The later 2 are also called protective reaction. The forward parachute reflex is triggered by suspending the infant ventrally and dropping him suddenly with the head directly towards the surface. The action elicited by this maneuver is symmetrical and characterized by finger extension, spreading of the fingers, dorsal wrist extension, arm extension, which must be present in order to label this reflex as being present, and arm separation. All 5 components must be present to call a complete forward parachute reflex. This reflex is not present at birth. Very few infants have developed this reflex by 3 months of age. By 12 months of age, it is present in just about all infants. This reflex is influenced by visual and vestibular cues. Its appearance is related to the infant's need to avoid injury from falling while learning to stand and walk. The lateral parachute, also referred to as propping reaction, is present in 90% of infants. It is elicited by tilting the infant to the side while holding the infant in a supported sitting position. It is manifested by arm extension and abduction to the side of the tilt. It is first noted at 6 months, and soon after it becomes incorporated to volitional motor activity. The backwards parachute reflex is triggered from a sitting position. The infant is gently and carefully pushed back. The action triggered by this maneuver consists of bilateral arm extension. This reflex is first noted at about 9 to 12 months of age, and a few months later it gets incorporated into volitional motor action. One frequent question about parachute reflex is timing. Pressed for a specific timing of the initiation of these reflexes, I would say that the lateral parachute is first present at 6 months, the forward parachute at 9 months, and the backward parachute at 12 months. So the answer to this question is C. Next question. A full motor reflex can be expected in a neonate as early as weeks gestational age. A25, B35, C37, D20. The motor reflex should be fully developed at birth. Some authors believe that it is a flight or fight response triggering the production of adrenaline and cortisol, thus giving energy to the baby during the birth process. It is present, according to some authors, in an incomplete form in utero as early as about 9 to 12 weeks. It is present in late premature neonates and in full-term neonates. The motor reflex is the only primitive reflex that has multiple sensory triggers, including loud noises, a sudden movement or change in position, a frightening visual imaging, or unpleasant feeling on the skin. The actions triggered by any of these stimuli varies according to gestational age. In this frame, I have schematically represented the evolution of motor reflex from 28 to 37 weeks. At 28 weeks gestational age, it is confined to extension of the fingers. At 32 weeks gestational age, in addition to extension of the finger, there is separation of the fingers and extension of the arms. At 35 weeks gestational age, in addition to the previously actions, the arms abduct. And at 37 weeks, the full motor is present with follow-up hugging-like motion. This reflex is integrated by the time the infant is about 3 to 4 months of age, prior to the infant achieving complete head control in prone position. So the answer to this question is C. Next question. Which of the following reflexes is less likely related to progression during the birth process? A. Bauer, B. Gallant, C. Perez, D. Batkin. Some primitive reflexes are involved in the progression of babies during delivery. This is a logical conclusion based on what else could this reflex be there for, other than to exercise the muscle in utero, propel the baby out of the uterus during delivery, change the vector of the forces generated by the uterus, and generating a fight or flight response. 6 primitive reflexes are involved in the delivery process. 5 of them have the Bauer reflex, characterized by forward progression when the sole of the feet are stimulated. The Gallant reflex, this reflex produces lateral motion of the spine, thus changing the vector of the forces generated by uterine contraction. A similar function has been linked to the asymmetrical tonic neck reflex, also to the tonic labyrinthine reflex, and the motor reflex. The other one, the one not previously mentioned and apparently involved in the same task, is the Perez reflex. This reflex is elicited by running your index finger or thumb along the spine from the pelvis upwards to the neck. This maneuver causes the baby to lift the head and bottom, bend the thoracic spine backwards, and bend the lower and upper limb. The Perez reflex is active in utero during the last 2 to 3 months of pregnancy, hence it is found in premature and full-term neonates. This reflex is gone by 3 months. The Perez reflex was first brought to the attention of physicians at a conference in Barcelona and later published in the Revista Española de Pediatría. The photographs you see in this frame are from that article. Interestingly, in the original article, it was reported that the motor activity elicited was sometimes accompanied by a strong cry, leading in many cases to glottic spasm with apnea and occasional cyanosis. The last reflex listed in this question was the Batkin reflex. This reflex is triggered by suddenly pressing on the palms, as you can see in this frame. This action elicits opening of the mouth and flexion of the arms. This reflex is present in neonates as early as 25 weeks, and it is gone by 5 months. At this time, it becomes integrated with eye, hand, mouth volitional activity. The 2 photographs in this frame capture a neonate just before and while the maneuver is being performed. Notice the opening of the mouth. The opening of the mouth is not associated with crying, so the answer to this question is D. Next question. The abnormality presented in the drawings below are consistent with dash reflex. A. An exaggerated, B. An obligatory, C. A fragmented, D. An incomplete. The table in this frame lists the reasons primitive reflexes and postural reactions can be called abnormal. As you can see, some of the reasons are intrinsic to the event, while others are related to chronology. Among the intrinsic characteristics that can render an event abnormal are an exaggerated response. We can find a good example in the positive support reflex of some patients. This reflex can be triggered by holding the baby vertically around the trunk and bringing the baby down until the sole of the feet touches a flat surface. The action elicited by this maneuver changes with age. Normal infants in the first 3 months of life, the baby will only at times extend the legs and only for a few seconds. From 3 to 6 months, this maneuver elicits a reflex extension of the hip, knee, and ankles. At this time, the legs are stiff as corresponding to a reflex motor activity. After 6 months, the position will be similar, but the rigidity will be gone because the activity will now be integrated to volitional activity. When this reflex is exaggerated, we find a stiff scissoring of the lower extremity. An obligatory reflex refers to a response that cannot be interrupted by a second maneuver. In the neonatal period, the actions elicited by the asymmetrical tonic neck response consist of extension of the limbs on the side of the face and flexion of the limbs in the occiput side. In normal circumstances, if while this posture is maintained, the infant is presented with a new stimulus, let's say that the infant is presented with a stimulus consisting of the skin over the pubic being stimulated, we would provoke a reflex extension of both lower extremities with adduction and internal rotation into talipes equinus. In a patient with an obligatory asymmetrical tonic neck reflex, pressing the skin over the pubis will not influence the patient's position. A fragmented reflex consists of a reflex that is missing midstream components of the motor actions expected for the patient's age. As we have mentioned before, the parachute reflex has 5 components. A fragmented forward parachute is one in which extension of the arms, that is the 4th component, is missing despite the presence of the normal 5th component. Notice that in this example of a fragmented forward parachute, the arms are abducted, which is the 5th component of the forward parachute, but not extended. We use the term incomplete to refer to a reflex when the last few components of the reflex are not present after the regular time of acquisition. I will go back to the parachute reflex to explain the concept of an incomplete reflex. An incomplete parachute forward reflex is one with no arm abduction at an age when arm abduction should be present. This term is also used to refer to a reflex with a missing action on one side, let's say lack of abduction, as you can see here, or lack of arm extension, as shown here. Chronological abnormalities can affect reflexes and postural reactions. As you recall, some reflexes and postural reactions develop in a chronological fashion. On the left side of this frame, I have introduced the motor reflex evolution from 28 to 37 weeks. On the left side, I have attempted to represent the temporal evolution of this reflex. The motor reflex, like all primitive reflex and postural reactions, have a period of emergence, when new actions are becoming incorporated into the reflex, a period of maturity, when the reflex is stable, and a period of dissolution, as the reflex disappears or becomes incorporated into evolutional action. Pathological conditions can affect this process, producing different manifestations. Probably the most common chronological abnormality is the absence of a reflex, as depicted here by the flat red line. Pathological events can arrest the development of a reflex. This eventuality is characterized by an initial normal development followed by the lack of further progression, as you can see depicted by the red line. Another chronological abnormality is the delayed appearance and evolution of a reflex, as you can see here, again represented by the red line. The last abnormality is persistence, referred to a mature reflex that should dissolve but does not, as you can see represented here. I will go back to this list one more time to tell you that intrinsic abnormalities may be associated with central or peripheral nervous system pathology, whereas chronological abnormalities are usually associated with central nervous system pathology. So the answer to this question is B. Next question, what should you not do if you find a patient with an abnormal primary reflex or postural reaction? A. Refine your neurological exam to elucidate abnormality at the site of pathology suggested by the abnormal reflex. B. Start physical or occupational therapy if the abnormal reflex involves trunk or limb musculature. C. Tell the family the patient will have cerebral palsy. Deciding what to do when we find an abnormal primary reflex or postural reaction can be straightforward. Let's say we are performing a cross-extensor reflex test in a normal 1-month-old infant. To elicit the cross-extensor reflex, one leg is held firmly in extension and the sole of the foot is rubbed. The action triggered by this maneuver is observed in the opposite leg, and it has 3 successive phases. The initial phase consists of flexion at the hip and knee. The second phase consists of extension and adduction of the free leg towards the stimulus side as if to push away the stimulus, and the third phase consists of fanning the toe. The time course of this reflex is rather specific. At 30 weeks of gestational age, we can elicit a partial form, only the first phase flexion is present, and at 34 weeks we can elicit the full reflex. The cross-extensor reflex then disappears by about 2 months. Now let's say that you are examining a 1-month-old patient. You do the maneuver to trigger a cross-extensor reflex of the right leg and it is normal. Then you do the same maneuver to test the left leg and you find no reaction. In this case, you should suspect a left lumbar sacral plexus palsy. But if, on the other hand, the same maneuver is followed by knee flexion and fanning of the toes, but there is no leg extension, you should suspect a lesion in the femoral nerve after the iliopsoas muscle have been innervated. In such cases, the action is straightforward. Investigate the suggested possibilities, but often the course of action is not straightforward. A good example is when we find a Babinski sign. The Babinski reflex is triggered by stimulating the lateral sole of the foot towards the small toe, as shown here, and then changing direction towards the big toe. This maneuver may trigger extension of the big toe and fanning of the other toes, to which we refer as a Babinski sign. Yet, the plantar responses to the maneuver used to elicit a Babinski sign can yield different results. In some patients, the toes remain flexed. In others, we find bilateral Babinski signs, while in others, we find unilateral Babinski signs. What should we do? Is it abnormal? In 2002, in a large cohort of apparently neurologically normal infants studied by Dr. Kumar, it was found that bilateral extensor responses represented in blue in this table decreased with maturity, but were still present at 12 months of age in a significant number of patients. In this study, fanning of the toes was not used as a criteria. Hence, we can say that bilateral incomplete Babinski signs are about just as likely as bilateral flexor responses and asymmetrical response in 9 to 12 months infant. So the physician, finding an asymmetrical plantar extensor response, may decide to tell the family of the finding and explain the significance of it, that it may be a sign of neurological lesion, which will greatly stress the family, or sit on the finding and risk delaying diagnostic or therapeutic interventions. This decision is further complicated by the many articles that associate abnormal primitive reflexes and postural reactions with motor problems in healthy preschool children, attention deficit and hyperactive disorders, autism, and cerebral palsy. So the way I would answer this question based on the least common of all the senses, common sense, is not to tell the family the patient will have cerebral palsy. Thank you very much for your attention.